the height schedule. I'm not concerned about it because we have nearly plenty of space, so we can also move some of the space up the bench.
Okay. Good morning. Thank you very much. Muchas gracias for this opportunity to be here. I thank the folks from Abbott. I thank Ricardo Ceballos, forgive my Castilian Spanish, Ceballos. And for me, I think the raison d'etre, the reason for being of an academic physician is teaching. And to have so many people here and to be able to share my experience is a tremendous privilege. And I like to come to Mexico too for the culture. So, this is a master's course. This is not a beginning course, so you're going to have to work a little bit. And I'm going to give you some information that's a little bit detailed, but I hope, excuse me, there's something for everybody here that you can take home. So why do we need eye movements? We have sharp, detailed vision only at the fovea, the center of our retina, and images to be seen and analyzed must be held at the fovea steadily. So we have eye movements that assure these visual functions. So, we have eye movements which bring images to the fovea, saccades, the rapid eye movements we use to search our environment, and vergence, what we call fast vergence. Excuse me. We have two eyes, so we can move them quickly to change the depth that we are looking at. And once at the fovea, we have to keep the image quiet. So we have vestibular movements. When we move our heads, we have pursuit movements, which allow us to track targets. And we have slower vergence. A few more details. Saccades are usually voluntary. They're triggered from the cerebral cortex, but quick phases of vestibular nystagmus are also saccades. They are reflexive, and they're triggered in the brainstem. We have pursuit, which also is triggered by the cerebral cortex, usually voluntary. And again, we have vergence movements. The eyes move by different amounts or in opposite directions, and they're often voluntary as well. And of course, we've heard about vestibular movements. They're called the slow phases of nystagmus. They allow us to see clearly when our head is moving, rotating, or translating. And we also have what is called ocular counter-roll, torsion, when we tilt our head to one side and change the head position relative to the pull of gravity. So here's a little video which just shows all these types of eye movements. And these are saccades. The subject is being asked to look back and forward between a target and my nose, a finger and my nose. We look to see how rapidly they are initiated, their speed, their accuracy. This is pursuit. The subject is being asked to follow a target moving across the visual field, just like this. And this is a vestibular ocular reflex, a doll's head, if you will, at a pretty high frequency. Most of this is from the vestibular system. This is cancellation of the vestibular ocular reflex. We're following a target, moving with the head. We are canceling the reflex. The eye is still in the orbit. These are vergence movements. Far, near, far, near. And of course, this patient is very athletic. He won a gold medal in the eye movement Olympics. The point I'm making is you can examine all the eye movement systems very quickly, very quickly. The anatomy. This is the essential core of localizing and understanding eye movement disorders. You have to know a little bit of the anatomy. For horizontal gaze, all conjugate commands, pursuit, saccades, vestibular, gaze holding, finally reach the sixth nerve nucleus in the pons. What does the sixth nerve nucleus contain? Motor neurons, abducens motor neurons that innervate the lateral rectus muscle, and importantly, abducens interneurons. They send their axons across the midline, they ascend in the medial longitudinal fasciculus, and they impinge on the medial rectus subnucleus of the third cranial nerve. Vergence movements are different. They have direct access to the third cranial nerve in the midbrain. They do not require the medial longitudinal fasciculus. So let's take a simple diagram. And if you remember one bit of anatomy today, please remember this diagram. We have a brainstem, a pons, we have a midbrain, and we have our conjugate commands, saccades, pursuit, and vestibular, coming to the abducens nucleus, which is right there in the pons. And then we have our third nerve nucleus. And to make a leftward eye movement, the left eye goes to the left, right eye goes to the left. We innervate the lateral rectus, we innervate the medial rectus of the right eye, and we have a command coming from the abducens nucleus to the lateral rectus. That's the motor neuron. And then we have a command which must go up the MLF from the abducens internuclear neuron. Remember, both neurons there carry all the conjugate eye movement commands, comes up through the MLF, and finally synapses in the oculomotor nucleus. This is how we generate a horizontal conjugate eye movement. Vergence has its own special pathway. This becomes very important. So let's put this into practice with a few patients. So let's look at this patient.
Now, look right at the camera. Look to the right. Over here. Look to the left. And look straight. Look up. Look down. And straight. So horizontally, there's... Okay. Look at my finger. That's a conjugate movement. Look at the camera. Finger. Camera. Finger. Camera. And camera. White light, camera.
So what did we see there? Could she adduct her eye with a conjugate movement? No. The left eye would not go to the right. But how did we get her to adduct that eye? What kind of movement did we use to show that the muscle was actually okay? Vergence, exactly. So where's this lady? What does this woman have? This is a very common neurological syndrome. She can't adduct one eye. She has a little nystagmus in the other, and she can adduct it with vergence. Is this a vestibular neuritis? No. Does anybody know what this is? Is anybody here a neurologist? Okay. What is this? This is internuclear ophthalmoplegia. Adduction weakness, nystagmus on abduction. These patients come in with vertigo and imbalance. You've got to know this syndrome. There's the lesion, right in the MLF, medial longitudinal fasciculus. And here's the simple anatomy that we can use now. The pathway carrying conjugate commands from the abducens nucleus to 3 is impaired. Vergence is intact. So this is a very characteristic neurological syndrome, the patients may also have other vestibular signs, which we'll talk about a little later. All right, let's try another case. Young woman with sudden onset problems looking to the left.
Now try and look to the left, way over there, left, where the window is.
I can't.
Try your best.
Yep, I'm trying.
Okay, now look at the camera.
Mm-hmm.
Look to the right. Now look as far as you can to the left. Right, and as far as you can to the left.
Let's look at another clip.
My finger, camera.
How's she doing up and down?
Jude, would you just stand behind, please? Camera. Camera.
Virgins is
Now
good.
Look to the hammer over there. Okay, look at the hammer. Okay.
So if you look carefully, she goes up and down just fine. When she converges, this eye now moves a little bit to the left. Now let's look at the last clip.
Right at the camera, please.
This is vestibular.
Right at the camera.
Does she do any better with vestibular?
So with the VOR, there's no real change. Okay, look at the camera.
Mm-hmm.
Go ahead.
Even with head impulses.
Back, center, other direction. Good.
So here's a patient who cannot move either eye to the left, but with Virgins, she can move the right eye a little bit to the left, and she cannot move her eyes to the left with saccades or vestibular. Where's the lesion? Which nucleus? Let's take a vote. Third nerve nucleus. Who votes for the third nerve nucleus? Okay. Who votes? This is democracy. Everybody has to vote in Mexico. Who votes for the sixth nerve nucleus? Very good. This is the classical features of an abducens nucleus lesion in the pons. So now we've seen one in the MLF and one in the pons. This simple diagram and a good bedside exam taking about a minute tells you exactly where the problem is. It's not in the orbit, it's in the brain. Key points. The abducens nucleus contains neurons for all ipsilateral conjugate commands. Saccades, pursuit, vestibular, gaze holding. Virgins has a separate pathway in the midbrain to produce adduction of the eye. Vertical movements are spared, and a pontine paramedian reticular formation lesion, we'll talk about that in a second, just affects saccades, not everything else. So let's talk a little bit about saccades. The signals for horizontal saccades come from the cortex, the colliculus, and they end up in the pontine paramedian reticular formation. That's right here. So let's go back to our diagram. Here's our conjugate gaze pathway. This is for saccades now. The PPRF, the pontine paramedian reticular formation, is where the saccade neurons live. There they are, right there in the pons in the reticular formation. They project to the abducens nucleus. So, where is this patient's lesion?
Finger, camera. 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 Okay, finger, camera. Right at the camera. Finger, camera. Finger, camera. Up at the finger, down at the camera.
Okay, these are saccades. Are they normal? Are they normal speed? No. Are they fast or slow? Exactly. Very slow saccades. But does she get the eye all the way out there? She does. She does not have a conjugate gaze palsy. She has an isolated disturbance of saccades. They are slow. So where are the neurons that generate saccades? Pontine paramedian reticular formation. This is a disease of neurons in the PPRF, burst neurons that generate saccades. And this patient has a common form of spinal cerebellar ataxia type 2, in which, or Wadia Swami, in which saccades are very slow. So examining saccades in this patient allows you to pinpoint the diagnosis. Okay, well, let's move on to the vertical system. Again, the core of understanding neurological eye movement disorders is knowing a little bit of the anatomy. So, all the vertical gaze commands reach the third and fourth cranial nerve nuclei in the midbrain. The key structures. This rostral interstitial nucleus of the MLF, or RIMLF, it produces vertical saccades. It is the equivalent of the pontine paramedian reticular formation. We have the interstitial nucleus Cajal, which is right next door, and this produces gaze-holding commands, pursuit, and vestibular commands. And finally, we have the posterior commissure. It carries predominantly upward vertical gaze commands. So we have these structures in the midbrain which generate all the different conjugate commands for vertical eye movements. Now, the vestibular signals and the pursuit signals, they have a contribution from the vestibular nuclei, which ascends in the MLF. So, let's repeat that. This is difficult, but let's try and cement in our minds a few of these structures. Vertical saccades are generated in the rostral interstitial nucleus of the MLF. It's right up here. Vertical gaze holding depends upon the interstitial nucleus of Cajal and the posterior commissure. Those are those two structures. And vertical vestibular and pursuit signals come up in the MLF and a few other pathways close by. So let's see a patient. This patient came in, very interesting patient, with some confusion and bad headache.
Oh, that's good. Look way down. Way down.
That's hard.
Yeah.
That's
Look to the
hard.
right. Okay, look the other way. And look straight ahead. That's very good. Look right at the camera. Look up. And look way down. Look straight ahead. Now I'm just going to move your head a little bit. Okay. Look right at the camera.
So, isolated vertical gaze palsy, predominantly down, with an intact vestibular input. This is a characteristic picture of what we call top of the basilar syndrome. It's a stroke syndrome, very little defined on exam unless you look at the eye movements. So here's the lesions. They're in the caudal thalamus, the rostral midbrain. It's due to a single artery, the artery of Percheron. It's a subthalamic perforator, comes off the posterior cerebral artery and supplies both sides. So if you don't know what the eye movements are, you could show this MRI to a radiologist and he would find white spots all over the place and not give you any help. But if you look at vertical eye movements and see that the patient can't look down, you can nail the diagnosis. All right, now, just as a little aside, let's see you, and otolaryngologists will see these patients. The patient comes in because of balance problems for a year, and when you examine and has the same exam, cannot look down. What disease would you think of? Looks a little bit like Parkinson's disease. So progressive supranuclear palsy, or PSP. I think we'll get to that later today. So that's the top of the basilar syndrome, the artery of Percheron. Now, smooth pursuit is not as useful diagnostically because if the patient doesn't cooperate or if the patient is on anticonvulsants or other medicines, they may not track very well. Examining smooth pursuit is most helpful if the disorder, the abnormality is profound or if it's very asymmetrical. If it's profound or very asymmetrical. Let's look at this patient.
All right, let's do a little smooth pursuit. Look at my finger.
A little downbeat nystagmus, and that's pursuit. It's very choppy. The patient can't generate pursuit movements that are smooth. The patient must use saccades to catch up to the target. So they substitute saccades. So this is impaired smooth pursuit in a patient with cerebellar disease. The last little bit of anatomy is the structures that are responsible for holding gaze. If you can't hold gaze, you have nystagmus. So in the medulla, we have the structures that are important for holding horizontal gaze, and that's the medial vestibular nucleus and the nucleus prepositus. And for the vertical system, I've already told you this, we have the interstitial nucleus of Cajal. So 3 nuclei to remember. Interstitial nucleus of Cajal for vertical, and medial vestibular nucleus and nucleus prepositus for horizontal. We'll come back to those when we talk about nystagmus later. So the cerebellum is also very important for gaze holding, the flocculus and the tonsil or paraflocculus. We won't belabor this point because we'll get to that. Let me show you a few examples where the patient cannot hold gaze.
My finger.
So this is vintage gaze-evoked nystagmus. The saccade is okay, it's fast, it's accurate. Gaze is full, but the patient can't hold eccentric gaze. This is a problem in the gaze holding network. So let me give you a little bit of, this is gaze-evoked nystagmus. What if I told you this patient had hyperemesis gravidarum? She was pregnant and vomited, lost a lot of weight, was malnourished, and came in with this nystagmus. What would be your diagnosis, and how would you treat this patient immediately? Wernicke's disease. What would you give them immediately?
500.
Vitamin B1, thiamine, 500 milligrams intravenously. It's an emergency. Don't miss this diagnosis. The last little bit here in a couple minutes, I'll just touch on the cerebellum. I'm just going to show you 2 examples of saccadic disorders in the cerebellum, which are very precisely localizing. When you have patients coming in with imbalance, you have to try and figure out if they have a vestibular problem or a cerebellar problem, or both. And if you're going to look for a cerebellar problem, the best way to look for it is to look at saccades, or one of the good ways. And we're interested in these structures in the cerebellum, the vermis and the underlying deep nuclei, vestigial nucleus. Here's a couple examples.
Now look at my finger and the light.
Are these accurate
Finger,
saccades,
wait for the command.
or do
and
they
the
overshoot?
Light. Finger, 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 light.
Okay, what did we see? Were the saccades fast? Yeah. Could they have a full range? Yes. Could the patient hold gaze eccentrically after the saccade kind of quieted down? Yes. This is a problem of saccadic accuracy. Accuracy. Just doing this. Overshooting almost every time. And this is typical for a lesion in the deep nucleus, the vestigial nucleus, which you see there at the arrows. Let me show you one more.
My finger.
These are saccades.
Eyes wide open.
Now look carefully.
Camera.
Are they overshooting
Camera. Okay.
or are they undershooting?
Camera. Finger. Camera. Finger. Camera. Finger. Camera. Finger. Camera.
So the first patient we saw before this overshot. This patient is undershooting, making a whole little series of small saccades. I want to show you that once more. One of the objects of this meeting today is to hone, to improve your skills at the bedside. You don't need fancy recordings to detect anything I've shown you. You just need to know what to look for. Well, let's watch it again.
Camera. Eyes wide open. Finger,
Little
Camera.
series of
finger,
saccades.
camera,
Some of the best things in life are very small, you know.
camera, finger,
Little series of hypometric
Finger.
saccades.
camera.
And this is typical for saccadic hypermetria, a lesion in the vermis, right here. So the cerebellar vermis with Purkinje cells, a lesion there gives you hypometria. If the lesion then involves a deep nucleus, you get hypermetria. So the last videos I'll show, and I'll be promptly done in 30 minutes, has to do with the cortex. So a lot of structures in the cortex. Saccades come from the frontal lobe and the parietal lobe. Pursuit comes from the frontal lobe and the back end of the brain, these areas, MST. Let me just show you an example of what a typical patient with a large stroke shows. So, this lady had a hemispherical stroke. Look at her saccades carefully.
Camera, finger, camera, finger, camera, finger, camera, finger, camera, finger. Stop for a second. Let's do the other side. Finger, camera, camera, finger, camera, finger, camera.
So, this is a little difficult to see, but I'll show it again. Who saw some difference between making saccades to the right and the left? Right, correct. When she went to the right, it was a big one. When she went to the left, there were usually a couple small ones. Let's see that.
Finger, camera, finger,
One, we'll look at it one more time.
camera, finger.
Single
camera,
one to the right,
finger,
3 or 4
camera,
little
finger,
ones to the left.
camera,
1, 2, 3.
Finger, camera, finger. Stop for a second. Let's do the other side. Finger, camera, camera.
Single to the
Finger,
right and a couple
camera.
to the left. So this lady had a large lesion in the right cerebral hemisphere, a stroke. She made hypometric saccades to the left. Now, the last video, let's see what her pursuit is like. Remember, I said asymmetrical pursuit is helpful.
Look at the tip of the pen.
Tracking to the right is not so good. Tracking to the left is good. So she has trouble with smooth tracking to the right.
Okay, now look
And
right
with
at the tip of
saccades
the
to the
hammer and
left.
move the head slowly
This is
back and
vestibular
forth.
suppression.
Yeah, that's it.
Same
Go the other
thing.
direction now.
Good to the left, and
Right,
she
right
needs
on it.
saccades to the right.
Real right on it.
That's probably a little harder to see. Okay, so she had impaired pursuit and VOR cancellation to the right, toward the side of the lesion. So the summary of this is saccades generate contralateral saccades, pursuit generates ipsilateral pursuit. If you have a lesion in one hemisphere, you have trouble generating saccades in the opposite direction, and you have trouble generating pursuit in the same direction. So that's it for a little brief potpourri, introduction, eye movement control. Naturally, all these diagrams are available to anybody who wants them, and I will stop right now.